Today, Dr. Pees is here to discuss Loeys-Dietz syndrome. We've only recently formally expanded our charity to support patients with Loeys-Dietz, so this is momentous. Welcome, Dr. Pees.
Thank you very much for your invitation. I'm just giving this brief talk about Loeys-Dietz syndrome, the similarities and difference to Marfan syndrome. I presented this talk a couple of weeks ago here in Vienna at the MEN meeting, so I hope there are not so many people attending that meeting too, so that would be a little bit boring for them. We'll just start briefly with the Marfan syndrome and Loeys-Dietz synonym. It's a little bit confusing all the names during the last centuries. We had the first description of Marfan's patient from Antoine Marfan in 1896, and we got the first description of a Loeys-Dietz patient actually in 1993, but in that time the patient was named Marfan syndrome type 2. And since last year's symposium in Antwerpen, we have 8 different genes found by now who are causing Loeys-Dietz syndrome. I will just go briefly to the diagnosis of Marfan syndrome. We do have different combinations. Either you have aortic root disease, or we have a combination of aortic disease and ectopia lentis, or you have a combination of the aorta and the systemic score, or the third, it would be the aortic root dilatation and the fibrin 1 mutation. It would be a little bit easier if you have a family history of Marfan's disease, so you can just confirm the genetic results. This is a picture of the diagnosis of the systemic score. You can all see the different parts which are subsumed under the systemic score. And I really wanted to focus on this young lady here, on her facial appearance. And if we come to the next picture, you see the typical picture of a Loeys-Dietz syndrome patient. So we do not have this long face. We have a broader face with the hypertelorism, which is a widely spaced eye. And we have a cleft palate with a beefed uvula in a minimum form or a really cleft palate. And on the right side, you see from behind a heart and an aorta, which is extremely elongated, S-formally shaped, and has tortuous arteries up to the head and neck vessels. This trial was the ground place for Loeys-Dietz syndrome naming. So if we come to the next picture, we have by now 8 different forms. So I will just focus a little bit on the type 1 and 2 syndrome, Loeys-Dietz syndrome. As you can see here, the typical facial appearance. We have Marfan-like symptoms in Loeys-Dietz patients with the scoliosis, with the chest wall deformities and the long fingers, as well as the aortic root aneurysm. But we have as well the hypertelorism I just talked about and the tortuosity of nearly the whole arterial tree. And we have much earlier problems with the aorta, earlier rupture and earlier death in Loeys-Dietz patients. In 70% of Loeys-Dietz patients, we have cervical spine malformations, which can cause frequent need for surgical stabilization, and it can be identified in all age groups. And we do have allergic predisposition, which is in 60% really highly elevated than in the general population. We do have a lot of food allergy problems in patients, and we have as on top a gastrointestinal inflammation up to 10%. So if you have a look onto this picture, you see that we have 3 parts of Marfan syndrome: the ectopia lentis problem, the skeletal features, and the aneurysm problem of the aorta. And Loeys-Dietz syndrome can overlap with Marfan syndrome in a minimum of 2 parts, with the aneurysm problems as well as the skeletal problems. We do not have ectopia lentis in Loeys-Dietz syndrome, but we can have other eye problems. So how can we distinguish between these aneurysm disorders? First of all, we can focus on the syndromic problems. We have the facial appearance, and you see here we have the long, thin face in Marfan syndrome, but as well in arterial tortuosity syndrome and in vascular Ehlers-Danios syndrome. And we have the telorism in Loeys-Dietz, but we can see it as well in Mees-Loeys patients as well as in microduplication 7q11. I talked about the skeletal features. We have the long fingers in Marfan syndrome, but we can have even other problems with crumbling feet and fingers in Loeys-Dietz syndrome. We have the split uvula, but not only in Loeys-Dietz, but as well in Mees-Loeys syndrome and arterial tortuosity syndrome. And I talked about the different eye involvements in these two different diseases. And we have different aortic aneurysm locations. We have the typical ascending aortic dilatation in non-syndromic hereditary thoracic aortic diseases and from time to time in Turner syndrome. And we have the aortic root aneurysm in Loeys-Dietz and Marfan syndrome, as well as in Mees-Loeys syndrome. Next. And if we have a look onto the ascending aorta, we do have to take very good look onto the aortic valve as well. Normally have a three-partite aorta, which is called tricuspid aortic valve, but in around to 2% of the general population, we can have a fusion of two valve leaflets. So we have a bipartite aortic valve, and this can happen a little bit more often in some of the genetic disorders. As you can see here in an ACTA2 mutation, but as well up to 70% in Loeys-Dietz patients and in 30% of the Turner patients. We can have a persistent ductus arteriosus in some of the some of these disorders, especially in Loeys-Dietz, but as well in Mees-Loeys syndrome and in non-syndromic hereditary thoracic aortic diseases. I talked about the arterial tortuosity, which is very pronounced in Loeys-Dietz and in the name-giving disease arterial tortuosity syndrome, but as well in autosomal recessive cutis laxa type 1b, and in some of the Marfan's patients, especially in neonatal Marfan's patients, one can see tortuosity as well. And two specific diseases, the arterial tortuosity syndrome and the cutis laxa 1b, can have pulmonary artery stenosis, and in Turner syndrome, we are well aware of aortic coarctation. And in the two mentioned diseases here, we even have venous vessel involvement and from time to time even diaphragmatic hernia. So a good part is to go for the genes to really try to find a good diagnosis for every patient, to keep the clinical picture and to go for genes. But it's not the gene by itself to get the diagnosis. As you can see here in this table, the FBN1 mutation can cause different diseases, the Marfan syndrome, but as well only the isolated ectopia lentis or the Weil-Marchesani syndrome, but you even can have really the opposite of Marfan syndrome, like the stiff skin syndrome or the galophysic dysplasia type 2. So one can ask, why it is actually necessary to distinguish? We have a really broad spectrum of phenotypical aspects in Loeys-Dietz syndrome. As you can see here, we have the highest problems in TGF-beta receptor 1 and 2 patients, the Loeys-Dietz type 1 and 2, where we have systemic features. We have a really early onset disease with a dissection even below the size of the aorta of below 45 millimeters. And we can have Loeys-Dietz patient with TGF-beta 3 mutation with only mild expression or even non-penetrance. So it is absolutely it's a really high need for getting the right diagnosis to really tell the patient when it's time to go for elective surgery of the ascending aorta. We have a really high malignancy in Loeys-Dietz syndrome type 1, 2, and 3, where we would operate at a size of the aorta of 40 millimeters. In Marfan syndrome, we can wait a little bit longer, and we do have other syndromes where we can even wait up to 50 to 55 millimeters. So the diagnosis is necessary to really distinguish between the aggressivity of the disease. But even if you know your disease, if you know you have TGF-beta receptor 1 and 2 mutations, saying Loeys-Dietz type 1 and 2, there is a broad spectrum of phenotypic showing up. We have patients with really early onset of the disease, even in early childhood, and we have familiar cases where you can't really see the typically facial features in the patient. And if you have a family with the same mutation, you can have a mildly affected parent and have a really severely affected child. So it's a really broad spectrum of these diseases, even with the identical mutation. I just wanted to show you why all the syndromes really resemble each other so much. We come a little bit to the molecular substrates. You see the aorta here on the left side, which is a three-partite vessel with the inner layer, the intima, the media, and the outer layer, the adventitia. And we will focus on the media, where most of the genetic problems will be caused. You see here in red the muscular cells with the thin and the thick elements, and it's connected to the elastin fibers, the pinkish ones. And most of the non-syndromic hereditary thoracic aortic diseases are caused by genetic disorders in the thin or in the thick filament. We have a second molecular substrate, the extracellular matrix, which is in between the muscle cells. It's consistent of elastic fibers and as well collagen. And if you see elastic fibers here on the right side next, it is built up out of tropoelastin and cross-linked with a lot of different tiny parts, which can all be diseased by a genetic disorder. And the elastin fiber is scaffolded by microfibrils, which are consistent of fibrillin 1 and 2. And so you can see here every single bit can be diseased and causing a different disease. Next part is the proteoglycans, which are the tiny bottle brushes here in between, giving the texture this tensile and and elastic tissue context by producing swelling pressure. But if it's destroyed due to a genetic problem, due to a gene variant, we can have Ehlers-Danios syndrome problems, or we can have the Mees-Loeys syndrome. As well, Turner syndrome is thought of being connected to biglucan problems. So how can we connect Loeys-Dietz with Marfan syndrome a little bit better? We know since a couple of years that fibrin is not just only connective tissue fibril, but it can as well act as a stabilizer of TGF-beta in an inactive form. If fibrin is destroyed or is built up improperly, TGF-beta can be freed from the TGF-beta binding protein and react to its receptor here in the picture, and can activate the cascade of TGF-beta receptor 1 and 2 complex by activating SMAD2, 3, and so on. And all these parts you can see are parts of the Loeys-Dietz problem. We have the activation of TGF-beta due to problems in fibrillin 1 formation and activating of TGF-beta, but TGF-beta receptors can be activated by angiotensin 2 as well, which is normally blocked by losartan, a good working medication in Marfan syndrome. But as I told you, TGF-beta receptor 1 and 2 are mutated in Loeys-Dietz syndrome. And it took a little while to find out why a genetic disease causing a loss of function of these receptors cause as well TGF-beta augmentation in the tissue. And here you can see it. Our aorta is not built from one embryological part. It's built up from different parts, and the ascending aorta is built from the cardiac neutral crest cells and the aortic root from the second heart field. And we have a decreased TGF-beta activity due to Loeys-Dietz mutations in the second heart field area in the aortic root, and these cells sense the decrease and try to compensate through secretion of more TGF-beta in the local environment. But this TGF-beta secretion needs angiotensin 1 receptors, and this is why the losartan therapy works in Loeys-Dietz patients as well. Thank you very much for your attention, and I'm happy to take questions.
Thank you so much, Dr. Pees. That fantastic compare and contrast. Does anyone have a question? This is more a comment actually than a question in the chat feed. Terry's son has mutated SMAD2 Loeys-Dietz, which I think you said, I recall from Vienna, was rare. You hadn't come across a patient with SMAD2.
Actually, I don't take care of any of the SMAD2 mutation patients. So nearly up to 85% of all Loeys-Dietz patients are Loeys-Dietz type 1 and 2. And these are, as you would have seen in the picture with the phenotypical differences in the different types of Loeys-Dietz, are the ones normally the most aggressive. So these are the ones presenting early in life, even in childhood. I think SMAD2 mutations are known since only a couple of years, probably forming a group where only tiny bits of patients are known by now. So it's really a hard thing for doctors to counsel on patients who are really, really rare and really, really seldom. I do not take care of SMAD2 patients because they are so rare.
Angus has asked for you to say something about types 4 and 5?
Again, type 4 and 5 are normally patients presenting later in life. So since I'm a pediatric cardiologist, I do not have patients of type 2 and 4 and 5, but they can have all the same problems in the aorta, sometimes presenting a little bit with less syndromic features like the hypothyroidism is seen, but not as many skeletal problems, but it really depends on the patient. As I showed you, the phenotype in even one form of Loeys-Dietz can vary a lot, and even in families with the same identical mutation, the phenotypes really can be from one end of the spectrum to the other one.
Thank you. And Julian's asking for interpretation. Does Dr. Pees' last comment mean that ARBs like losartan and irbesartan are most relevant to the aortic root dilation, but not so much to the aorta beyond that?
Actually, we use angiotensin receptor blockers for Marfan patients a lot, and we know that it works quite good on the aortic root. But Marfan patients normally have problems in earlier years at the root, and it starts to augment in problems in adolescence, or even in patients, especially in patients being operated on the ascending aorta, in the descending parts. We do not have really many problems in children at the abdominal aorta. So I'm not really keen in how aneurysms of the abdominal aorta can be treated by angiotensin receptor blockers, but it really works good at the ascending aorta, and it can stop as well the growing of the descending aorta. So about the abdominal aorta, and especially about problems in the cerebral artery tree, I'm not quite sure about that, but since we take angiotensin receptor blockers in Loeys-Dietz patients as well, it should protect these arteries a little as well.
Thank you for clarifying that. And Andre wonders, from what age should we start treatment for aortic root dilation, or from what Z-score?
Normally, it is considered to be taken from diagnosis on, but especially if you talk to parents having a young child, telling them to take a medication whole lifelong in a 2-year-old or even a 1-year-old or 4-year-old is a really, really long time. So I'm normally starting medication if the parents and the patient wants to, with a Z-score of 2. But even in between a Z-score of 2 and 3, I have a couple of families saying, it is so early, it's not really growing so much, can't we wait? And between 2 and 3, it's a little bit of a gray zone for me. I don't force patients. It's better to have them on your side, that if you start medication, they really take them and not stop and take and stop and take all the time. But after Z-score of 3, I'm really forcing medication, really hard.
Thank you. And Julian's just commenting in response to your answer to his last question. I'm basically asking about the ascending aorta and arch. Understand that abdominal is different. Glad to hear ARBs are relevant beyond the root.
This is what I really see in patients being operated and having problems in the descending parts of the aorta, that we can really stop it to grow faster after operation with losartan as well.
I don't think any further questions have emerged, but thank you so very much, Dr. Pees, for sparing your time today. That was phenomenal. Thank you.
You're welcome.